Well, we're starting this all over because my husband called me and upset me quite a bit. Because I just called him before I started recording and said, "Don't call me, I'm going to be recording." So here we are, fixing to start all over again. So rest assured, this is my second attempt, and it may be more than this one before we get through with it. That's why Saturdays are usually the best days to record because nobody bothers you. Ah, he said he pocket dialed me. I don't know if I believe him or not. What do you guys think? I think he just did it so I'd mess it up, and I had to totally redo it because you would not want to hear what I had to say about him calling me in the middle of my recording. All right, let's try this again. Of course, you don't know it's again because you didn't see the first go around. That does make a difference. I could have never told you that, and you'd have never known the difference. All right. I only spent 20 minutes talking. Now I'm talking all over again. All right, infusion therapy. Advanced infusion therapy. Um, it is the RN's ultimate responsibility to make sure that all aspects of infusion therapy and delegation is done correctly. We are regulated by the Infusion Nurses Society, and that's what all our information is based on. That's what all of our checkoffs are based on. The common reasons that we usually do IV therapy is to either maintain or correct fluid or electrolyte balance, give medications, or, as you can see, this little bag of blood, to administer blood products. LPNs can actually start IVs in some places, and some places they cannot. Depends on the facility's policy and your state board practice, scope of practice. Infusion therapy basically is just exactly what it says it is. It is a method of delivering medications, fluids in a solution by parenteral route. Intravenous therapy is our most common route. We have other routes like intraosseous, interspinal, blah, blah, blah. We have all those different ways we're going to talk about here in just a little bit. The IV therapy is one of our most common invasive therapies that we do inside the hospital and that nurses do to patients. It's one of our most common ones that we do. It's more common than Foley catheters. There are sometimes specialized infusion teams that will go around through the hospital and start all the IVs that need to be started, and this is very cost effective for the hospital. It also makes for good patient satisfaction because they get a team of experts that can start an IV with just one attempt and usually know where to put it and how big of a needle to use, and if possibly that peripheral line may not be good enough, they will know to ask for a PICC line or a central line. So we have better patient outcomes because they know exactly what type of site and what type of route we should use. Here again, you may see that in a smaller hospital, if you can't have a full-time infusion team, you've got some nurses that can't start IVs very well, and then your patient satisfaction goes down. We do several different types of infusion therapy with our therapy fluids. Our IV solutions that we have, that also includes our TPN. We have blood and, of course, blood components, and then we do drug therapy. Remember, when we do drug therapy with an IV, we should always have drug therapy in as a secondary administration set. It should never go in with a primary, just in case there's reactions or you need to take that, you need to have more fluids, but you don't want to have all the drugs. Our intravenous solutions are hypertonic, hypotonic, and isotonic. It goes within the normal range of osmolarity is isotonic, and that helps us keep the fluid from shifting into the cells. The hypertonic and the hypotonic. The hypertonic is when we have greater than 300 osmolarity, and the hypotonic is when we have less than 270. You will learn more about this when you have your fluid and electrolyte lecture right before spring break. Miss Smedley will be doing that for you guys. We're going to talk just skim the top of electrolytes and fluid balances. The isotonic infusate, water doesn't move in or out of the body. So water doesn't go out of the cells. It stays all in the intravascular spaces. So it's in the venous system or arterial system. It's in your vascular system. Therefore, we see patients who are very high risk for fluid overload. So we have to monitor and watch for signs of fluid overload. I hope that each and every one of you know the signs of fluid overload. You start seeing restlessness. You start hearing crackles in their lungs. They start having shortness of breath. They start becoming anxious. These are all signs of fluid overload. So anytime you have someone on an isotonic fluid, you need to be monitoring for fluid overload. And isotonic fluids are like normal saline and lactated ringers. These are the two that we see most often. And remember, normal saline is the one that we use with blood products. And only normal saline. You can't use any other solution to give blood products. Then we have our hypertonic infusate. This we use to correct fluids, electrolytes, and acid-base imbalances by moving water out of the body cells and into the bloodstream. So if someone, comes in and they're very edematous and we want to get those fluids out, we would put a hypertonic infusate along with some diuretics to get the water out of the cells and into the bloodstreams. One example of a hypertonic infusate is the parenteral nutrition, the TPN. Is an example of that particular one. When we have a hypertonic infusate where our patient is at high risk for phlebitis and infiltration rather than fluid overload. Our phlebitis, of course, is the inflammation of the vein caused by mechanical, chemical, or bacterial infections. That's when we'll see phlebitis. And over here in your book, for some reason this chapter is not as well put together as I would like for it to be. Iggy's usually a lot better than this. We have a phlebitis scale on page 209. Your table 13.6 gives you a grading scale for phlebitis. 0, of course, is no symptoms, and it goes all the way up to 4. Usually 1 is just you have some erythema with or without pain, and then number 3, you've got pain with the erythema and edema or not, and so forth and so on. And I'll let you read down through there and be sure and look at those so that you'll know what they are. Also, the infiltration, of course, is just when that IV fluid leaks out into the tissue, and it's usually cold, hard, and swollen at the site. And we also have an infiltration scale that's on the same page on table 13.7. So please be sure and look at that so that you'll know how to, when you are in the hospital, if you find an infiltrated, you don't just say IV infiltrated. You will be able to say IV infiltration scale at 3. Skin blanched, translucent, greater than 6 inches in any direction from the site, which is a pretty good size infiltrate, isn't it? Would be for me. I don't know that I've actually ever had an IV get that large and infiltrate. So that's all I want to say about that. Then hypotonic infusate. It's been a long morning already. We do that. We give that to move water into cells and expand them into the cells. So we got somebody that's dehydrated. We may want to do some hypotonic infusate to give them fluids, and the fluid move from the vascular spaces into the cellular spaces to be able to rehydrate. These patients are also at risk for phlebitis and infiltration. Also, if we give any type of medication through here, that the pH should be 3.5 to 6.2 of our solution. If it's extreme of either one of those, if it's lower or higher, we're going to see a high risk of phlebitis and thrombosis. We should not use any solution, hypertonic or hypertonic, anything in a peripheral line if we have pHs above or below those levels. We should use central lines, never use a peripheral line. So remember, if our osmolarity is greater than 600, it's best to infuse it in that central circulation with a CBL line, PICC line, where greater blood flow is going to provide adequate hemodilution. That word low got me. This is not my PowerPoint. I just picked up the PowerPoint from the book and made it my own, but I didn't check the spelling. So that should say where greater flow instead of low provides adequate hemodilution. TPN has a osmolarity of greater than 1400, so that's something we would never ever put in a peripheral circulation. It can cause a lot of damage to blood cells and the endothelial lining of the vein, so we want to make sure that we know what the osmolarity is of our fluids. Hopefully our pharmacist will say, hey, you can't run this in a peripheral line, it has to go through a central line or a PICC line. That's what we're hoping anyway. Vesicant drugs like chemo, vancomycin, and things like that should really be run through peripheral lines. If it should be run through central lines. If they're run through peripheral lines and they leak into the tissue, they cause extravasation. They cause extravasation like blistering, tissue sloughing. Thing you want to do is stop the infusion and leave the catheter in place to be able to give a possible antidote or antivesicant to try to keep from damaging the cells any further than what they are. Blood transfusions and other components, this is all going to be covered in your hematology, so the only thing I really want you to be sure that you know is that blood products have to be given with normal saline. And other than that, Miss Smedley is going to cover that quite well for us when she does hematology. So, administering IV medications. Medication safety is a big issue anymore, especially with our drugs that are high alert. A lot of our electrolytes are high alert drugs. Our potassium especially has become a high alert drug. I remember when you could find potassium sitting all over the counters here, there, and everywhere, but now it's become a high alert drug, and usually the pharmacist will mix it in your fluids, and you are not allowed to mix it at all, and you don't usually give potassium push of anything. It usually goes through IV fluid and is mixed. So other things that help us with our medication safety, of course, are 5 to 6 rights, whichever you do with the medication checks. Be sure that you are using electronic medical records correctly. Be sure you're scanning bands and scanning what you need to scan to make sure that everything is correct. And of course, if it's a particular drug that's a high alert drug, you should be double checking that with another nurse. Our drugs always, with an IV, will have rapid therapeutic effect. So if you're going to give somebody Demerol, don't give them Demerol IV and then them say, I need to go to the bathroom. You need to say, do you need to go to the bathroom before I give you this drug, because you're not going to be able to get up because it works very quickly. So be sure that you're aware that you have a rapid therapeutic effect with that drugs. Never assume that IV administration is the same as giving that drug by other routes. We all know that, IV Demerol, you have to give more of the PO drug. So if you were given 50 milligrams of PO and you decided to give it IV, you wouldn't give the same, you would give less because the PO has to be more. So you want to be sure that you don't assume that IM is going to, or PO is going to translate into the same dosage as what you would have with IV. Be sure that when you are doing infusion therapy that you have doctor's orders so that you know what's been prescribed, and you need to make sure that it includes what type of fluid, the rate, if any drugs are supposed to be added to it, the generic name of the drug. Make sure that it says it's for intravenous route. The frequency, you may have an intermittent saline log. Medication, of course, can be the IV piggybacks can be given every 6 hours or every 4 hours or whatever. Length of infusion, and sometimes you have to put the purpose down depending on what your facility policy is. A lot of times we get our IV antibiotics are coming up to where they're either pre-mixed, or all we have to do is pop a vial that's already attached to the IV bag and mix it. And so we're not doing like we used to do 20 years ago, where we had to actually draw it up, mix it, and then put it into the IV bag. It really has helped prevent a lot of infections and medication errors by having the pharmacy mix them and then we give them. But that doesn't relieve us of the duty to make sure that that dosage is correct in our medication that we give. Okay, so we have different type of vascular access devices, and we're going to talk about each and every one of these. This is just a list of the ones we're going to talk about. Our peripheral IV therapy. This is the one most of us are most familiar with, the one that we will be doing. We will, all of us will start IVs in the clinical areas. We will be encouraged to start IVs. We will seek out starting IVs as students, as RN students in this program. The short peripheral catheters are usually placed in the superficial veins, usually in the dorsal surface of the hand or the forearm, but best practice has dictated, when I first started, it was start in the hand and work your way up. Now it's don't use the hand unless you absolutely have to, especially in an active adult or an older patient or even a child. If you can get it up in the forearm, it's much better. And instead of starting in the hand. Of course, you always work proximal to where the IV was started if you're going to have to restart the IV. Dwell time. Our dwell time used to be that we would have to leave the IV in 72 to 96 hours, and even though it was a good patent IV, we were supposed to remove it and insert it into another site. Now, the best practice is that we base this on clinical indications as to whether or not that IV needs to be replaced. If you have an IV that it took 6 people to get in and it's still good on the 3rd day and it's still good on the 4th day, and you don't really want to jerk it out and try to have to stick her 6 or 7 more times to get that one IV when you've got a perfectly good IV. So we only need to remove that IV if it's clinically indicated in that it's starting to have infiltration, phlebitis, infection, any type of clinical indication that we should move that. If we're going to have therapy, if we know we're going to be doing therapy, IV therapy for more than 6 days, a peripheral line shouldn't even be placed to start with. We should just call the PICC line nurse and say, here, dude, come put this PICC line in before we waste all your veins and you can't get in there. We do have transilluminators available. I think they have started having these on the adult floors where you can use them. It takes a little skill to be able to use a illuminator because the veins look a little bit different, and even though you can see them on the transluminator, you can't actually see where you're putting your needle. You can only work it toward that way, so they're a little bit difficult to use. Different types of the peripheral catheters that you need to be familiar with some of the language is like over the needle cannula and through the needle cannula. That most of the IVs that catheters that we deal with in the hospital are over the needle cannulas. This is where the little plastic cannula is over the steel needle, and when we get the IV started, we pull out the steel needle and leave the catheter there, plastic catheter. The through the needle is where the plastic catheter is in the needle. This catheter does not have, even though the needle is the same size, you don't have the same barrel capacity in that catheter as you do the over the needle catheter, and you can give more fluids faster in the over the needle cannula, and you can give blood products in a smaller needle gauge in an over the needle catheter than you can through the needle catheter. Peripheral IV therapy carries a real high risk for blood exposure needle sticks because the cannula and the needle have blood in them. We have managed to decrease the amount of needle sticks because of the law that was passed a few years back that says all IV cathetons have to have a safety device on them that will retract the needle into the barrel of the syringe. So that has been very helpful in preventing blood exposure to needle sticks through the catheters. If you have a saline lock instead of an continuous IV going and you're giving medication through that, you want to be very careful about giving your drugs. You should push your drugs 2 to 5 minutes. The slower you push it, the less trauma you do to the vein. So you want to be sure that you're diluting and pushing your medications at a reasonable rate. Speed shock is something that can develop, and speed shock can cause, like if you were given Phenergan, it can cause the patient to go into terrible shakes and even more nausea, anxiety. It's really, so you have to really be careful with those. We want to avoid using any lower extremities, especially on adults, because of the increase of DVTs and infiltration. When we get ready to start this peripheral IV, we want to be sure that we choose the smallest gauge catheter capable of delivering the prescribed therapy and the shortest cannula that we can get. So on page 190, you have, I'll write these pages down and then I'll got to go find them. On page 90, it tells you how to choose the right gauge site for what you're using. And actually, they tell you, and I'd like to talk a little bit about this one, maybe at the table. A 24 to 26 gauge catheter, they've got down there to expect blood transfusion to take longer. These small gauges are usually preferred for infants. Even a 24 gauge is considered small for an infant. A 26 gauge, you're usually very seldom use a 26 gauge. 22 gauge is adequate for most people that are coming in and get an antibiotic therapy. Again, they say blood can be infused through a 22 gauge without damage. That's if you can give it slowly. So if you absolutely had to, you could give blood through a 22 gauge. However, most hospital policies tell you if you're going to give blood, you need an 18 gauge needle. So you should really, if you know you're going to be giving blood administration, you need to get that 18 gauge needle in there. Also, when you have a patient going down to surgery would prefer an 18 gauge needle. I don't like it when you stick in a 20 gauge needle and send them down. So 20 gauge needle is a pretty good size needle. In fact, that one you're looking at on your screen is a 20 gauge needle, and that's a pretty good size. And when you consider the cannula is over the needle, that gives you more room for blood flow or for fluid flow. So you can actually use it, but again, like I said, most of the time the hospitals prefer that you use an 18 gauge. So if you have patients coming in a trauma, and you know you're going to have a lot of fluid, or if they're having a lot of bleeding, you should put in an 18 gauge so that you can give that fluids, give those fluids quite rapidly. So remember where veins cannot be used. Now, in a mastectomy, if you absolutely cannot get a IV into the good arm, you can call the doctor and get an order to use any of these areas if it's absolutely necessary. But you cannot put them in there unless you do have a doctor's order. If you put them in there without a doctor's order and there's damage occurs, you're the one that's going to be legally liable. So you want to be sure that you have a doctor's order if you cannot find a place to put your IVs at. Chart 13.1, placement of those short peripheral venous catheters tell you exactly where or where you should not put an IV. And I know a lot of, back in the day, we put them in the wrist. And wrist is absolutely a do not use because of that median nerve. So if you've got a patient that reports pins and needles, you need to take that out of there and go to another site. Even if it's not in the wrist, you shouldn't even be sticking the wrist to start with. So if you stick them anywhere and you feel, and they say, if you stick them in the back of the hand and they say they're feeling pins and needles, you need to stop because you're going through a nerve system. And we don't want to do that. We will damage nerves. We don't want to do that. So use the non-dominant hand whenever you're possible. You want to try to do a distal site. Like I said, we used to be told to put them in the hand, but you really want to start in the forearm now and then make them proximal to the previous sites. Don't put one in the antecubital space. Nothing gripes me any more than have a labor patient come in by ambulance and there's this big whomping 18 gauge needle right in their antecubital. And every time they bend their arm, the IV kinks off. So try to avoid those areas of joint flexion. They also cause phlebitis and infiltrations easily in those areas. If you find a vein that's really prominent and you go to palpate it and it feels hard or like there's a knot in it, that's probably a valve. You don't need to use that vein. Try to be sure that wherever you choose your site that you have a vein that's long enough to accommodate the length of your cathalon. And remember, we talked about be sure that your cathalon is the shortest length for what you need it to do. The longer the cathalon, the higher your rate of phlebitis is. You want to be sure to avoid that. So the most common site that we're going to be using for these IV sites is going to be the dorsal network, which is the hand. But again, like I said, we really should, and in infants, the dorsal portion of the hand is the best place to put it, other than the scalp vein, which most people don't like to use a scalp vein because it looks so bad. But the veins are very visible on the back of an infant's hand, and they're easily manipulated, and so those are the best choice for infants. But for adults, we really should be using the forearm. Butterfly needles, which are also wing needles, they're easy to insert, but they infiltrate really easy, so we try not to use those. Infection control. Well, of course, hand washing. Wash, wash, wash. Scrub, scrub, scrub. Make sure that you wash your hands. And if you're going to be putting this in a patient's area where their skin is dirty, you want to be, if it's visibly dirty, you need to get a washcloth with some soap and water and wash their skin to get rid of it. Usually guys that come in with really hairy arms, and some ladies have very hairy arms. We cannot shave in the hospital anymore because of the risk of cutting their skin, and so we want to clip the hair, and really the guys appreciate it and the hairy women do too, because when you go to take that Tegaderm off, it's going to pull all their hair off, and so they'd rather you clip it off than pull it out. And so you would want to do that. Of course, you always should wear your gloves. Once you prep your skin site with your chlorhexidine or alcohol, which most facilities are using chlorhexidine, and when you use chlorhexidine, you find your vein and you scrub in a perpendicular motion with a lot of friction for at least 30 seconds, perpendicular to that vein. You don't go back and forth across it. You don't go round and round. You go perpendicular up and down by that vein for 30 seconds, and then you have to let it completely dry. If it doesn't completely dry and you start an IV, then you're actually going to put that particular fluid that's sitting right there into that vein, and it may have some germs on it, and you may have exposed your patient to a life-threatening infection because you didn't allow that to dry. So be sure that you allow it to dry. Once you cleaned it and you dried it, there's a lot of nurses that I have seen, and I really do not. I will say something to you, and I will say something to them. Once you get that site prepped, do not, I repeat, do not go back and use your finger and fill that vein again before you stick, because you have contaminated your site and you will have to re-clean it. So if you do that, you're going to be in trouble. I don't know what kind of trouble, but we'll think of something. Midline catheters. We don't usually see a lot of midline catheters. Nurses don't usually put in midline catheters. I'm not even sure that they are available on the floors for the nurses to put in. They're quite a bit long. They're 3 to 8 inches long, 3 to 5 French. Is how they measure the size of these catheters. Usually insert a vein in the upper arm. You can leave them in for 4 weeks. And don't use any vesicant drugs, and don't draw blood from them. Your central IV therapy, your vascular access device is going to be placed in a central circulation area, usually within the superior vena cava near junction with the right atrium. Chest x-rays need to be done to confirm placement. So you should not use the central line until placement's been confirmed. They do have newer technology such as a magnet tip locator or a cavial atrial junction locator by EKG that can confirm them placement, but you have to make sure that you have that one of those to confirm placement before you use them. I know that at White River Medical Center they have this capacity to do that. The reason you would pick out central IV therapy over peripheral is, of course, your purpose, your duration, and if you've had problems getting peripheral line done. Here is our favorite little PICC line. We all like PICC lines. We see PICC lines a lot in the hospital. There's usually a designated PICC nurse. Matt Swaim is the one at White River, and I'm not sure who's at Unity, but Matt is has been doing it now for about 3 years, I think. Usually you have a length of the catheter catheter is about 18 to 29 inches, and you have to measure and cut to make sure that it is where you want it to be. You want to measure it before you put it in, and then you have to measure the external portion, and Matt goes over all of that in his PowerPoint for you to look at. So you should measure each time you change the dressing, that length of that's extending out past the skin needs to be measured to make sure that it hasn't migrated anywhere. So you also have to measure around the circumference of the arm. It's measured once it's placed, and then it's measured to make sure there's no swelling, and you have to measure it every day to make sure, once a day it needs to be measured to make sure there's no infiltration going on. You can, the most common vein that they like to use is the basilic vein. And if you'll notice that this catheter that they're showing us on this PowerPoint is actually in the basilic vein. So this is the reason they like to use it is because it's straighter and it goes straight up and then into the area. It's not as crooked as the cephalic vein, and there's not as much strain on it because it's on the inner side of the arm instead of the out part of the arm. Some of the complications that we see with these PICC lines are phlebitis, DVTs, and catheter-related bloodstream infections. Though they are less, the CRBSIs are a lot less common in the PICC line than they are in the CVLs. Always use a 10 milliliter syringe of normal saline to flush your lines. You should always use 10 mils before you give meds, then 10 mils after you give meds. Don't ever use anything less than a 10 mil barrel syringe. You really should use that for all your IV flushes because the smaller the barrel, the more pressure goes into the vein and can actually irritate or blow your vein out. So you want to be very careful with that. Although you can use a PICC line for just about anything, you can do rapid blood flow. Because it has the rapid blood flow, they don't have any limits on the pH or osmolarity, so you can do it. You don't have to worry about whether it's vesicant or not because of the large blood flow that's going through it. But one thing you need to be sure is if you're doing a blood transfusion that you use an IV pump because the length of the catheter doesn't allow the blood to flow as quickly as it should, so it needs a pump to get it to go through there. If you're going to be doing blood draws often and you're putting the PICC line in for that, you need to be sure you're using a large lumina for that, and the little caps on the end need to be cleaned very often and replaced as you do dressing changes, and Matt's going to go over that with us. Your non-tunneled percutaneous central venous line, that's what we normally see in the hospital if we're seeing these central lines. It's usually in the subclavian vein in your upper chest, can be put in the jugular veins of the neck. Every once in a while you'll see one in the femoral, but we have a high rate of infection with those. Chest x-ray, we have to make sure that we confirm that it's in the superior vena cava before we use it. The difference between our non-tunneled and our tunneled, if you'll look, you'll see in your right here the peripheral, the peripheral vein or the peripheral catheter ends right here, but the catheter itself continues on before it gets into a vein right here. This is supposed to anchor it better to tunnel it that way so that it isn't directly into the vein from here. So if it was jerked on, it might jerk out this way. It's supposed to have more stability. It's usually used for long-term infusion therapy. Usually has antibiotic containing material in a cuff to help reduce infection because they're tunneled into the skin. Our implanted port, our infuser port, we love these things. If they're going to have IV therapy for more than a year, like chemotherapy or antibiotic therapy, there's actually some things that have to be treated for more than a year, you should get an implanted port. Of course, this is a surgical implantation. It's we create a little subcutaneous pocket that's going to house that port body, usually in the upper extremity or upper chest. I've not seen any in the upper extremities, just usually in the upper chest portion. Some people's are easy to find and some people's are in pretty deep, so you have to, make sure you know where they're at and know how to feel for them to be able to access them. They all consist of your portal body and then that septum over the reservoir and then the catheter that goes from the reservoir into in the vein and takes the medication where it needs to go. They can be single or double. Most of them are single that I have run across. Although, you have to read to be able to tell what they are. You have to flush it after each use and at least once a month between therapies to keep it from clotting off. This one is good for people who are concerned about their body image. They get their port put in and then it's not visible and it's kind of like it's not there and they can forget about it. They can take showers, baths, go swimming, wear skinny shirts, whatever they want to do, and not be embarrassed by a line hanging out of their body. And this is what they look like, and this is what we will be doing. We will be accessing the Infusiport, and you have a check-off list that you need to look at and memorize and practice so that you can pass your check-off, which I know you can do. Hemodialysis catheter. I'm not going to cover this a whole lot because we'll cover it in renal. Just be aware that it's critical for management of renal failure, and you don't want to use it for anything other than the hemodialysis because you don't want to compromise this catheter at all. So we'll talk more about these when we get into renal problems. You can use it in an emergency. I think we were in clinical last semester and someone, they could not get an IV in this woman at all and she did have a shunt and the doctor finally said they could use it. So they don't like to use them. Our infusion system consists of our container, our administration sets, secondary, intermittent, primary. So these are things that you should pretty much be familiar with. Anytime that you go to get your IV fluids, even if it's in glass, you want to make sure that there's no leaks or breaks or pinholes. You want to check the turbidity, make sure that it's clear and not anything leaking out of it to make sure that there's no possibility of contamination. Our administration sets, we have primary, secondary, we have blood tubing, we have dedicated tubing, we have saline locks. These are all things that types of sets that we have. Our needleless system has been very conducive in helping prevent needle sticks, but there's been a question about whether or not we've had an increase in catheter-related bloodstream infections because of people not cleaning the connection sites where you insert your medication or your secondary IV fluids. So we want to make sure that we clean those hubs very vigorously. We should clean them with an alcohol pad very vigorously for at least 30 seconds. With our plastic ones, there are some medications that's not compatible with them. Insulin will hang on to the inside wall of the tubing and you're not for sure how much dosage of that's coming through. Nitroglycerin, lorazepam, any type of fat emulsions or lipid-based drugs. And just because you've got a pump going on doesn't mean that you should not be watching the patient's infusion rate inside. Sometimes patients will change those on you, infusion rates on you. So you really want to make sure that you are monitoring your IVs and the rate and the side every time you go into the room. you should always check an IV site. Make sure it's not infiltrated. So we changed tubing. Lipid tubing should be changed every 24 hours. Blood tubing should be changed within 4 hours. So if you have 2 units of blood to run through, you can use the same tubing if you can get it to those 2 units infused in 4 hours. If not, you need to change your tubing. And then anything that has Diprivan in it or Propanol, you need to change that tubing every 6 to 12 hours. And of course, some hospitals will have deviations from there. Anytime that you're changing the CVL lines or the caps, be sure that your patient is placed either in Trendelenburg or at least flat, and that you have them do the Valsalva maneuver as you are changing, removing the line and placing the line on there to prevent any type of air emboli. And of course, anytime you have an IV in an arm, be sure that no one's taking blood pressures in the arm that the IV's in. That's a really big no-no. When you go to remove your short peripheral IV, you want to be sure that you pull out laterally and toward the catheter. You don't want to pull away from it because you could pull the catheter out before you're ready to pull it out. Once you get it, the Cathalon, get your tape loosened up and pull the Cathalon out. Be sure you're holding pressure. You should hold pressure for about a minute at least, and make sure, at least until you make sure there's no bleeding. No more bleeding, and you want to assess the tip of your little Cathalon to make sure there isn't any missing piece of the Cathalon. If there is, you need to, of course, report that. Removing a PICC line is a little scary. You want to go slow and easy with that one. If you feel any resistance, you want to stop. Perhaps distracting your patient, because sometimes they get anxious, their muscles tense up, and it causes the PICC line to stick. It's called a stuck PICC line. So you can distract them with maybe talking about their family, or maybe having them tell you about their disease process, or have them ask you any questions, any kind of distraction. Apply warm compress to it. You can have them drink warm fluids. You may even have to give them some medication to relax them. Of course, at the very last ditch effort, you have to call your doctor and see about, to tell them you cannot get it removed. You'll have to call the PICC nurse and have them come and see what's going on with it to see if it's actually stuck in there. So on table 13.3 are a big long list of your local complications of intravenous therapy. You can read that as well as I can read that, so be sure that you are looking at that. It's like 3 pages long, and then there's the systemic, which we will look at in a little bit later. Venous spasm. Sometimes you have a patient who'll start having venous spasm, so you want to, in order to relieve them of that, you can put a warm compress on there. Don't just immediately remove it. Slow down your fluids, maybe because the fluids were cold. You want to put warm compresses on that to try to get the spasms. So what are some of our systemic complications? They are listed on page 207 in table 13.4, which you can read. It's got on 13.4, it's got circulatory overload, speed shock, and catheter emboli. But it doesn't say anything about allergic reaction. But we all know allergic reactions can occur when you introduce a foreign body into the blood system, so that you may see an allergic reaction to a drug such as the Steve Johnson syndrome, or possibly even anaphylactic where they can't breathe and their tongue starts to swell. So these are things you really should be on the watch out for when you're doing those things. So in order for us to reduce infections when we're doing therapy, of course, not only hand washing, but trying to make sure we clean those clean those connections, that we don't tape connections. You've got a needleless system, there's no need to have to do any taping. And wash, 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 scrub your hands. We have alternative sites. Oh, I should have checked that. We have alternative sites instead of IV. We have intra-arterial, intraperitoneal, subcutaneous, interspinal, and interosseous. We will normally maybe run into intraspinal or interosseous, but the others are usually something you may see mainly in a chemotherapy area or in a CCU. The intra-arterial one is one that's used for chemotherapy, to get the chemo to the tumor site before it goes all the way through the body system and up through, to go through all of that. If they put it directly in the arterial one, it'll go directly to the tumor, and instead of going through all the filtrations in the body, and will be a lot better. The intraperitoneal, same way, it's going to target chemotherapy is going to target tumors in the peritoneal area, such as ovarian tumors. Subcutaneous infusion, you'll see that with these with the insulin pumps. You also can see it with pain medications, some subcutaneous infusion. We don't usually deal with that a whole lot in the hospital, although there's a lot of insulin pumps running around, especially on children. Intraspinal is usually used for pain control. This is your epidural and your intrathecal. Epidurals in your epidural space between the dura mater and the vertebrae. Given medication through the epidural has to diffuse through the dura mater, so it may have a reduced amount of medication going through, whereas the intrathecal is in the subarachnoid space and it goes directly into the spinal fluid, so you'll probably be able to give reduced amounts. Where I've seen them used is in OB, and to be honest, the intrathecal is very hard on a patient, makes them have a lot of vomiting, diarrhea just almost immediately. So you want to weigh your options with these things. Compartment syndrome, interosseous therapy. Compartment syndrome can occur with interosseous therapy. We usually do that. Trauma, burns, shouldn't be in for more than 24 hours, can cause osteomyelitis. Never put it in where a bone is fractured. That's a bad thing. You don't want to use an area where it's fractured. And I just covered that, but here's where you can look at the compartment syndrome, where tissue perfusion in a confined space is going to cause them to have decreased flow to the area, and it's a very dangerous thing. It needs to be taken care of. It's an emergency situation, no matter what caused it. Then with our older adults, those of you who have started IVs on older adults, even though they're thin-skinned, it may be tough skin. It may tear and wrinkle. They may have tortuous veins. Tape's going to cause their skin to tear or to bruise. They bruise very easily. You want to be very careful with cleaning their sites because they can't handle the friction that we usually do with younger adults. You want to be sure that you don't leave a tourniquet on these patients very long at all. You may even put a washcloth in between the arm and the tourniquet. Avoid those cord-like veins because they probably are cord veins. You might want to use a blood pressure cuff instead of a tourniquet so you can control how much you need. If they have very tortuous veins, you may just start it without a tourniquet. That's a big thing to do with these older people. I've seen people recommend the 3 tourniquet technique, and that's where you put on 3 tourniquets. That is never to be used on an old person. It's very detrimental to their veins. Some of their cardiac and renal changes are going to affect how we give our fluids, making sure we don't give our fluids too quickly, and that they don't have their renal output. Their drugs are going to maybe become toxic because they can't filtrate those through. So those are some things that you have to watch for in older adult care. Want to answer some questions? Okay. What's the primary intervention the RN implements to prevent a central catheter related bloodstream infection for a patient having IV therapy? Okay. Well, we all know hygiene's good, right? Hand hygiene's always good. All right. Ensure the dressing remains intact. Now, question the need. Clean the hub. Well, we know clean the hub for 15 seconds is not long enough, so we can eliminate D. Question the need for one. I don't think we got to worry about that because it's already there. So we probably want to be sure that we do. Ensuring the dressing remains intact. Sometimes they don't have dressings. And hand hygiene is probably going to be a more correct answer. So A is the answer to that one. We figured that one out. Good job. Alright, we have a man with 90% burns on his body. They couldn't get an IV. What type should we use? Well, how long does it take to put in a PICC line? Well, we've got to call the PICC nurse in. What if she's not on the floor? They got to get their equipment together. That's going to take quite a while. Central line, same thing. Got to go to surgery or got to have a surgeon put that in. Subcutaneous infusion, certainly not going to meet his needs for IV fluid replacement. So C, intraosseous catheter would be the obvious choice there. Good job. And during the insertion of an IV catheter, patient with dehydration, pins and needles, what are we going to do? Alright, what caused the pins and needles? Well, I think I just told you this one not long ago. The patient's nerve puncture may have occurred, so you need to actually stop what you're doing and go to another site. And that is all of this one. Oh, there is one more thing I wanted to talk to you about, is documentation. When you do your checkoffs, you are required to document. And it never fails that the student comes in, does their checkoff list, and then they get to that documentation and they look at me and they say, well, what am I supposed to put here? What's considered documentation? Well, your book has a list of things in there what you should document for IV therapy. So you got to stop and consider what you're doing. First of all, you want to make sure that you write down the date and the time. You know, January 18th, 2016 at 0900. Explain to patient procedure fixing to perform. Patient verbalizes understanding, gives verbal consent. Huber needle, 22 gauge, 1 3/4 inch long. Inserted after sterile technique. Inserted sterile technique after appropriate cleansing of the site. Or you could eat, and patient stated, blood return, good blood return, push pause method used, And guys, I'm just pulling this off the top of my head because I've not looked at it yet. But these are things I want you to consider, and then patient stated, that it didn't hurt at all. You did a really good job. Did better than the last nurse did. Patient educated on to be careful not to pull uh, on his lines that were out, and sign your name and stuff. So those are things that you want to be sure you're doing there. So you want to have the date and the time, your name of the person that did it. If you're doing an IV access, you should have what vein you use. If you use a basilic vein, cephalic vein, the dorsal vein, you should have that on there. The type of your vascular access device. Are you using a Cathalon? Are you using a Huber needle? What are you using? How many times did you attempt to do that? Where was those attempts located? What was the response of the patient? What type of dressing did you put on this patient? We'll put a Tegaderm dressing with a Statlock on with our PICC line and with our Infusiport. That would be a type of our securement device. Did we put any kind of special barriers on there? And then our education that we had. And then when you go to discontinue it, you just make sure you put your date, your time, everything that you did, and make sure that your pressure held, length of your catheter when you took it out, whether the tip was intact, bleeding, if there were any bleeding, assessment of the site, was there any edema, redness noted, pressure held, band-aid applied, patient's response, education to leave the band-aid on for at least 24 hours, and etc. So be sure that you don't come and look at me and say, what am I supposed to write here? Because I can't tell you what you're supposed to write there at that point in time. So when you're doing your practicing, practice your documentation. Look and see what you should be documenting, and be sure that you're putting in all the things that are important. You don't just go in access port, patient stated okay, and sign your name. That's not going to get it. If you leave the time and the date off, that's not going to get it. So be sure that you do those things. And that is the end of this PowerPoint.